Welcome to NP Certification Q&A, presented by Fitzgerald Health Education Associates. This podcast is for NP students studying to pass their NP certification exam. Getting to the correct test answers means breaking down the exam questions themselves. Leading NP expert Dr. Margaret Fitzgerald shares her knowledge and experience to help you dissect the anatomy of a test question, so you can better understand how to arrive at the correct test answer. So if you're ready, let's jump right in.
Mrs. Parr, an 82-year-old woman with a 30-year history of hypertension and dyslipidemia, treated and at evidence-based practice goals, presents with a 3-day history of weakness and urinary incontinence. She was seen in an urgent care center yesterday, diagnosed with a UTI and appropriately treated. She resides with her adult daughter, who states, the last 2 days, Mom keeps saying that she needed to get to work. She retired 15 years ago. She's never been confused like this. The NP understands that with delirium, the changes in mental status is usually A, occur rapidly and are associated with an acute illness, B, are noted over a number of weeks and typically progressive, C, irreversible and slowly advancing, D, without a predictable pattern and often noted in the absence of acute illness. The correct answer is A, occur rapidly and are associated with an acute illness. Where do we start here? First, what kind of a question is this? Given that we've been provided with a possible diagnosis, being delirium, and then as to how this syndrome will present, this is an assessment question where additional information needs to be gathered. Let's take a look at some background information. Delirium, quite common in the older adult, is actually a condition, indeed a syndrome and not a diagnosis, in which the patient exhibits an acute onset over hours to a few days of reduced ability to maintain attention to external stimuli and shift attention appropriately to new stimuli. The result is disorganized thinking. 2 or more of the following are usually noted: an altered level of consciousness from baseline, memory impairment, perceptual disturbances such as hallucination, altered sleep, change in psychomotor activity, and disorientation to time, place, and person. In this patient scenario, the report of Mrs. Parr's needing to go to work when she retired 15 years ago reflects that disorientation to time and perhaps place. Delirium is triggered by an acute underlying change in health, with the most common reason being infection. And number 1 and number 2 infection reasons for delirium are UTI, and number 2, which is a distant second, is community-acquired pneumonia. When you look at all the reasons to develop delirium, UTI will be at the top of the list. And you might say to yourself, oh, wait a minute, there's no report of dysuria, there's no report of fever. This is often how UTI presents in the older adult. Weakness, confusion, new onset wetting, that's it. Additional common causes include medications with the ability to cause sedation and fractures. And fractures are most often viewed as being the accumulation of being in pain, often needing to leave home to be hospitalized, altered mobility, and other contributors. Exactly what happens in delirium to cause these cognitive changes is not fully understood. One of the key features of delirium is the patient's return to baseline mental status once the acute illness is resolved. In the face of severe, long-lasting illness, the mental status changes usually improve as the person recovers. For a person such as Mrs. Parr, with a typically time-limited illness like a UTI, her cognitive changes will likely resolve within a few days. However, the weakness associated with UTI in the older adult, a feature that's usually not seen in 25-year-olds with this condition, will likely linger for a number of days, greatly increasing her risk of falling. This information, of course, must be shared with patient and caregivers. Delirium should not be thought of as being an inevitable part of acute illness in the older adult. Rather, avoiding the common triggering illnesses for delirium should be the goal. And with that in mind, think, and I've covered this on another program, how can you help avoid UTI in an older woman? The use of periurethral perivaginal estrogen can be very helpful for recolonizing the area with protective bacteria like lactobacilli. Community-acquired pneumonia, how can you prevent that? Flu shots, COVID shots, and pneumonia vaccine. There you go. We've got a lot of ways that we can help prevent the common triggers. And the other part, of course, safe prescribing. With this information in mind, let's take a look at the question and the options. Mrs. Parr is an 82-year-old woman with a 30-year history of hypertension and dyslipidemia, treated and at evidence-based practice goals. Presents with a 3-day history of weakness and urinary incontinence. She was seen in urgent care yesterday, diagnosed with a UTI and appropriately treated. She resides with her adult daughter, who states, the last 2 days, Mom kept saying she needed to go to work. She retired 15 years ago. She's never been confused like this. The NP understands that with delirium, the changes in mental status usually occur rapidly and are associated with an acute illness. Of course, this is the correct answer. In this case, the trigger was clear, the UTI. With this sudden onset change in mental status in the older adult, always look for that underlying cause. B, are noted over a number of weeks and typically progressive. This is incorrect and describes a health problem such as Alzheimer's disease. C, irreversible and usually slowly advancing. As was mentioned in option B, this better describes a neurocognitive disorder, something along the lines of Alzheimer's disease, or there are, of course, numerous other neurocognitive disorders that can be seen, particularly in older adults. D, without a predictable pattern and often noted in the absence of acute illness. Again, this is incorrect, particularly given that delirium's trigger is an acute illness. Key takeaway, a rapid change in brain function in the older adult should never, ever be dismissed as simply part of the aging process. Clinical investigation as to the underlying cause needs to proceed.
Thank you for listening to NP Certification Q&A, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit FHEA.com.